Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and leader at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. Today is Tuesday, August 11, 2020. The United States has registered almost 5.3 million total cases of COVID-19 with over 166,000 deaths. In Arizona specifically, courtesy of the Arizona Department of Health Services data, we are running at almost 23,000 cases of COVID-19 in patients under age 20. Keep in mind that Arizona does not distinguish the different age groups in this area, so we just know birth through 20. So that's 12% of the positive cases in the state. We've registered a total of 11 deaths from COVID-19, again in that same age group, less than age 20, which is 0.3% of the almost 4,200 deaths recorded to date in the state. So these are all important numbers. Certainly the more important numbers are going to be the trends and positivities, and both nationally and also in the state, we've seen a slight increase in the number of positive pediatric cases being demonstrated. This in part may be due to increased availability of testing so that less symptomatic cases and certainly contacts of known adult patients are able to be tested more readily. Maybe not in a timely fashion, but at least we're getting results at some point in time. But also, too, as we know, Arizona has just finished being number one in the world for its attack rate of COVID-19. So it stands to reason that our pediatric patients will now show increasing cases as they end up being secondary cases acquiring at home. So that is sort of a general overview of the epidemiology of where we stand today in the second full week of August. The questions this week are in large part a holdover from the WebEx or panel session which the chapter hosted a week ago past Monday, talking about the issues surrounding school reentry. And I had the pleasure and honor of serving as a panelist on that WebEx. There's such a great number of questions and a variety. I'm just going to try and take them almost individually rather than try and batch them. Although the first two questions, as we've had this debate many times before, ask in plain English, what is a fever? 99, 100, 100.4, 101, and even the suggestion of a fever is it depends. The official definition that is being used by the CDC and the AAP is 100.4, and that certainly has been used in studies which use fever as an inclusion criteria. I think we can all agree that children who have a febrile illness rarely hang out at just 100.4, so it's just a cutoff. The kids who have true infection, whether it's a rapid onset viral infection or otitis media or streptococcal pharyngitis, typically are going to spike a fever well over 101 Fahrenheit. So to the question of what counts as an inclusion criteria fever, the answer is 100.4 degrees Fahrenheit. Now, the next question is, if we have a patient, a child, who presents with fever, by that definition or whatever you want to use, and respiratory symptoms, and we're not able to test that child, or perhaps we don't have the result back yet, how do we instruct the parents about that child return to daycare or an in-person school if that becomes available? How are we guided? Well, and quite honestly, the CDC and the AAP account for this. If testing results are not available, and it is a possibility, or perhaps even a likelihood, that the child has COVID-19, meaning they were exposed to another family case, like a parent or something like that, then the child needs to be in self-quarantine for 10 days from symptom onset and at least 24 hours fever-free without also receiving an antipyretic, such as the acetaminophen or ibuprofen that we have been administering. The question goes on to ask then, what about the parents? So let's say that whether it's a known or not known COVID-19 pediatric case, do the parents have to self-monitor for another 14 days after the child completes the 10 days? No. the parents and the child are all under the same 10-day self-quarantine because presumably they all had the same exposure at time 0. So if it becomes a situation where we're needing to advise the parents as well, then the same CDC definition for how to remove from self-quarantine apply. It's 10 days from onset of symptoms or 10 days from a known exposure. If one wants to be absolutely safe, let's say parents are working in a high-risk field, then 14 days is offered as a more conservative time of self-quarantine. But again, the 14 days starts from time of exposure. If a child has fever or respiratory symptoms, what is the guideline for returning to school? Yeah, we just answered that. It does not rely on a negative COVID test plus fever-free because keeping in mind there's going to be a false negative rate for the COVID test. If we have one, great, fantastic, wonderful. Certainly, if the child tests positive at the start of their illness, a negative COVID test as I guess, evidence of resolution is not necessary to come out of isolation. It is absolutely a time-based and fever-free based criteria. So 10 days out from onset of symptoms and or positive test, regardless of doing any secondary COVID testing, and fever-free for a minimum of 24 hours without antipyretics. How significant do the symptoms need to be before we have to consider the patient a suspect patient, or even notifying contacts from school to start a contact investigation? Well, that's the problem, especially as we enter flu season coming up and not so very long from now, because even today, kids can have rhinovirus, they can have adenovirus, they could have non-COVID-19 disease. So really, the contact investigations and the notifications need to be reserved for those cases that either are tested positive or in whom it's highly likely. You'll note right there, I just inserted some subjective element there. It's meaning that we as healthcare providers absolutely need to be able to make our own determinations, and every case needs to be treated on an individual by case basis. So, if you have a child who has fevers and some respiratory symptoms, and there's a known contact at home with whom they spend a lot of time, that's pretty darn likely that they also have COVID-19. However, if it's just the child with the same symptoms and no other positives and no known exposures, it would only be if that patient then tests positive that we would need to investigate contacts and notify the school. The question about club sports. So on the panel session, we had an excellent discussion about school sports, so related to school districts. What about external or extramural club sports? This is, as with the school sports, a pretty, pardon the pun, hot topic because, yes, many of these sports are occurring outside where the risks of transmission are less. So what do we recommend to the parents and even to the patients in our practice about return to club sports, given that many of those clubs have already started practices? It's the same issues, meaning that if social distancing is difficult to achieve, and I understand that may be in some closed team sports, those clubs need to provide clear, transparent guidelines, or not even guidelines, criteria, I'll say that, for identifying students or athletes who may be symptomatic, and those students need to be screened, evaluated, tested, quarantined, the whole 9 yards. If and this would be my personal advice where I ask this question in practice. If the club sport is unable to provide a clear, transparent protocol for response to possible COVID-19, then I would strongly encourage the parents to keep their child away from that club sport, knowing that that's horrible and difficult and will be the worst parents ever. Oh my gosh. But safety's got to be very important here. And the same goes for having a reasonable, transparent, set in evidence-based stone approach to reopening the schools and school sports. Okay, on with that. I'm off my soapbox now. Thank you very much. Do schools need to do mandatory daily screening for symptoms? No. The screening approach certainly was a reasonable thing to try in the early days. Tucson Medical Center, where I practice, screen all of its employees entering the hospital campus and all the patients. We had, out of hundreds of thousands of screenings, no positives. There were no fevers, nothing whatsoever. So similarly with the school or even a job or someplace else, symptom screening does not seem to be an efficacious approach. And certainly, the temporal thermometer probes, basically, it's very difficult to reliably identify patients, even if they have fevers. So a symptom-based approach to screening is not going to be the way to go. Returning to, again, more questions about returning to school and a job. Does one need a negative test to return? No. Again, it's the CDC criteria: time from onset or time from positive test, and then fever-free for at least 24 hours. Similarly, if it's taking us longer than the 10 days to get our COVID results back, and that I understand is still a huge concern, and I agree with that. Are we stuck waiting until results come back before we can release the kids? No. Once again, time from onset, and if there was an initial positive, perhaps from an urgent care center or ED or something, that starts the clock ticking, and then it's 10 days out from that. This is interesting because it's something that I'd fully support. If we had the ability to do rapid turnaround testing with a high degree of sensitivity and specificity, would that be applicable to insert into the return to school approach? I wish we had access to that. I wish we had that degree of turnaround possibilities as well, because it would be helpful if we had a highly sensitive, specific test that we could get back in 45 minutes to use that at point of entry. I might have been feeling a little bit sick last night, but I'm okay now. Hey, let's just do your oral swab. That would be even great if we could do it by oral instead of nasopharyngeal swab. So stay tuned for that. Certainly the pace of discovery in all things COVID-19 related is incredible. So it's not unreasonable to think that we may have a rapid turnaround sensitive specific test in the not too distant future. And if so, then I would propose that we think creatively how to insert that into our return protocols. Alrighty. One question is a holdover from the panel discussion. Does the negative COVID test, which we were talking about, have to be PCR, or is an antigen test acceptable also? Well, keep in mind that we don't need a negative test to guide the return to school. This is really, we want instead the symptom, the length of time being symptom-free. But what about the tests which are available to do our community testing, to guide the hopefully 2 sequential 7-day periods of decreased infectivity in the community? The antigen test, compared head-to-head to PCR test, which has not been done effectively, however, seems to have slightly less sensitivity than does the PCR test, which makes sense. Like we're detecting expression of antigen with infected cells. So if we have a positive test, great. That's inclusive. That's a positive. But a negative antigen test may not carry the same weight as a negative PCR test. And certainly in terms of guiding community onset-based protocol thinking, I think we need to either look at the overall universal trends and or try and focus on the PCR tests. Oropharyngeal versus nasopharyngeal swabs, and now increasingly the possibility of a saliva test. Again, I have not seen, at least I've not seen published, a head-to-head comparison of the sensitivity and specificity of those 3 testing modalities. As the recent recipient of a nasopharyngeal swab, as I got thankfully entered into the Moderna vaccine trial. So I got my shot this past Saturday, and prior to that had to be NP swab tested for active disease. That thing is no joke. Gotta say, it was not pleasant at all. So I would be a huge fan if we had a sensitive oropharyngeal swab or even a saliva test. The challenge here is not just the specimen, but the presence of virally infected epithelial cells. The nasopharyngeal swab is obviously going to be the most effective way to get that because that's where the virus goes. That's the target of opportunity. Oropharyngeal swabs and even as a third level, saliva, are going to be increasingly less likely to have the appropriate epithelial cells, which will drive the sensitivity of the test. So I'm not giving you an answer because I don't have an answer to give you. My suspicion is that we will find NP most sensitive, oropharyngeal less sensitive, saliva not that sensitive at all. A positive from any of the three, however, is probably likely to be very specific. So take all those with a grain of salt and wait for the head-to-head comparison, which I imagine is coming out sometime soon. Siblings of a child who has a positive test. Or if we have, for example, a kindergarten through 5th grade that is able to cohort their students, a cohort member of a positive test. Does the exposure need to stay home for the 10 to 14 days? No. And the drawn out no is with a grain of salt because the CDC would say they simply need to symptom check or self-monitor for the 10 to 14 days after the index patient in their cohort or at home was found to be positive. The grain of salt is that we all know that the kids are far more likely than not to be asymptomatic or to be subsymptomatic, and also how to get a young child to self-report the fact they just don't feel great. Yeah, parents can tell. I absolutely agree with that. But the sensitivity of that pickup is not great. However, the current approach is just to provide or expect self-monitoring, self-reporting from the families of the cohorts and keep our fingers crossed. Let's see. Here's a next question. What about creative solutions? What about prioritizing younger children for the in-person return to school and keeping older children? Yeah, you hit the nail on the head. That's exactly what we were talking about during the panel discussion. The South Korea study and more recently, although the data has not been released yet, from Italy, all show that 0 through 9 years of age had only a 5% attack rate of causing secondary cases at home versus 10 years old through 19 years old that had an 18% attack rate of causing secondary cases. That rate of attack is similar to even higher than adults. In fact, it is higher than adults aged 30 through 49. So our middle school and high school age students are absolutely known to transmit cases very reliably to their close contacts, to their families, far more so than the kindergarten through 5th grade students. So yes, I would absolutely support a phased return to in-person school, prioritizing indeed those younger children, kindergarten, preschool age through 9 years, as perhaps an early introduction to in-person school, followed by, as community rates continue to improve and hospitalization rates continue to improve and the trends are good, followed by those things, by then the return to middle and high school students. Absolutely. How about kids with chronic medical issues? And we have quite a long list here, but things like asthma, congenital heart disease, patients with chronic lung disease, patients with autoimmune disease, certainly our kids who are on immunosuppressives of any nature. What are the issues involving sending those kids back to school in person? That's difficult because absolutely the immunocompromised or immunosuppressed patient is at higher risk for more severe disease should they get sick. The other sort of underlying chronic medical conditions, such as asthma, chronic lung disease, congenital heart disease, these are all comorbidities that in adult patients have been associated with risk for more severe disease. But that has not been reported in pediatric patients to any extent. But here's the problem. The reports that are out there are absolutely weighted far more to adult patients, of course, because kids in the United States represent at most 12% of the total infection rate in a community, at most. And more often, the average is around 8 to 9% based on the AAP's data from all the public state reporting databases. So So we don't really know. Um, my suspicion, or my I guess recommendation, if I can go on a record of saying this, is that patients are kids with underlying chronic medical conditions, and certainly those with any degree of immunodeficiency or immunosuppression, um, should be the last group of students to return to in-person school, and only when our community infection rates are well below the 5%. Although the governor currently is calling for just 7% infectivity, but well below 5%. Personally, I would love to see them go below 2% before we open up the schools to everybody. So it's a gradient, of course. And there are all the other factors which we discussed which need to be in place before reopening the schools to any of those patient populations, including social distancing, masking, hand hygiene, trends in the community attack rate, trends in hospitalizations, the whole 9 yards. This issue also applies to the next question, which has to do with precautions for grandparents. So again, presuming that a grandparent is going to be around or about age 65 and older, although of course we have younger grandparents. But I think the suggestion is those family members, how about this? Family members who are age 65 and older who have already a much higher rate of risk of serious disease should they become infected. How do we guide those families as our kids return to school? Well, again, I'd use that same phased approach, and so the kids from and preschool through fifth grade, 0 through 9 years of age, are going to be very low risk, not zero, but very low risk, 5% risk of transmitting disease to the older individuals at home, and so I would view that to be not as huge a concern. I guess luckily the overlap is such that's the same age student or child that actually might require childcare oversight, perhaps by the grandparent who's at home. So the middle school through high school, though, are going to be much higher risk, and I would certainly suggest, if at all possible, social distancing at home between that middle or high school age student and people, grandparents, etc., family members age 65 and older, just to be absolutely safe. If, however, the school has reopened under the context of very low community transmission, very reassuring trends, and all the proper precautionary steps taken, then I really think that it would be reasonable to avoid those restrictions and just return to business as usual. Similarly, grandparents of a newborn, when can they safely see the newborn and mother? Well, because thankfully both AAP and the American College of Obstetrics and Gynecology are strongly recommending screening mothers as they come in to deliver for COVID-19. We will know if there's a risk there. Asymptomatic but screen negative means very low risk both to the newborn and certainly to grandparents. And that data will be available by time mother and baby are discharged home, even if it's a rapid turnaround, 24 or 36 hours. So I think we need to answer the advice of grandparents for visiting rights really based on the screening results. Screen negative, A-OK. Screen positive, well, again, I would apply the CDC 10-day from time of onset to be absolutely safe because those grandparents are at such high risk. Some questions that I don't have great answers to, but I want to share them on this podcast just to get some thought processes and creative juices running. Will schools be requiring the parents or guardians to sign a waiver releasing the schools from liability should the student contract COVID-19? Would I recommend this action? Boy, I hate to get involved with legalese in this case. I do believe that any school decision to reopen needs to be done in as open and transparent a way as possible with parents of students, certainly the PTA, and have teachers involved. And if that's the case, if there is community buy-in to opening up the school, then I would hope that legal waivers would not be necessary. Certainly, I think if the schools are opening, they're doing so under, not order, but I guess acquiescence from the governor's office with the thresholds and by the local county health authorities. So I would suspect, without being a lawyer, that legal action would be difficult to carry forward. So Don't have an answer. I'm just sharing that for us to chew on. Similarly, some school nurses are reporting families intending to send medically fragile kids back to school. Reporting, I see, means to Child Protective Services. What's the best way to handle those conversations to keep the kids safe? Once again, I think once we enter an environment, time, and COVID culture where the risk is much lower, in which schools may be reopening, hopefully this point may become moot. Because medically fragile kids, as we talked about before, those certainly with underlying chronic medical conditions, need to be the last group of kids sent back to in-person school. And I would think that once we've achieved a very low community transmission rate and trends which are very low, then it would be safe and there'd be no concern for that. In terms of advocating for those medically fragile kids who of course need the same socialization and support systems they can get through in-person school, those may need to be advocacy which perhaps I and or the chapter can think about how to handle. And then certainly for those children who have IEPs in place, for their education plans, how do we support those kids to make sure they still meet the requirements set for their IEPs? That is an ongoing concern, and all I can suggest is as we hopefully transition from virtual learning to in-person learning, we'll be able to have a similar transition in requirements for those plans. Let's turn now, so this has all been sort of school-based and symptom-based and return from self-quarantine. The next set of questions, and I realize we're getting close to 30 minutes, but hopefully you'll give me a little bit of extra leeway here to keep on talking. The next set of questions have to do with infection prevention, and specifically, I would assume, related to the office, to the practice setting. The first is how to determine the amount of time needed for a clinic room to have adequate air exchange before rooming the next patient. So this, of course, depends on what's happening in that room. So a well-child check and no identification of concerning symptoms or signs, it would be an immediate. Certainly, it's reasonable to do a fairly rapid cleaning of the room, like, of course, wiping down the horizontal surfaces, obviously whatever one needs to do to the examining table. If, however, it's a sick visit and having sort of the healthy clinic in the first part of the day and sick clinic in the second part is an option. I realize that's not in any way logistically possible for most practices, but at least it is something to consider. Still then, if it's a younger child under age 10, the risk of aerosolization and droplet risks is quite low. So there would not need to be an adequate air exchange to occur before rooming the next patient, but it would certainly be reasonable to do the equivalent of a terminal clean between the patients. So wiping down the surfaces, with the bleach solution or with the quaternaries, just whatever your clinic is using. Those patients who are having an aerosolizing procedure, and specifically I'm thinking about are giving nebulized medications in the practice, or even doing like an MDI teaching, or perhaps administering an MDI, something like that. Yes, those count as aerosolizing procedures. And in the ideal world, with a hospital room with high air exchange, it's at least a 15-minute interchange of air exchange before proceeding with or rooming the next patient. In a clinic setting, though, which has just normal, in air quotes, normal HVAC systems, 30 minutes is a more reasonable to allow all those droplets to settle, and then a terminal clean, and then a rooming. Again, it's got to be a case by case. If you have a patient who's in there with an hour of continuous nebs, first of all, I would imagine one is arranging for EMS transport to the local ED, so they may not be there the whole hour. But of course, that would be a longer time period to let things just clear out. What about obtaining the nasopharyngeal swab? Well, in terms of aerosolization, and here we're talking the fine airborne particles versus the droplets, the risk is still small. Yes, we know that kids express virus more so in their nose than do adults, but we know they're also less likely to be contagious. Yes, the NP swab is likely to generate a cough, or at least in my case, tearing. Oh boy. But that's not the same thing as inducing a cough or a pertussive cough. So wearing the full PPE to obtain the swab, but after the swab is performed and the kid cries and they're consoled, etc., it is not going to be a significant risk of transfer. And so that is room that could be cleaned immediately afterwards, meeting Hawaii. How about we give it a couple minutes? Is that reasonable? Just to let any minor drops settle. A couple minutes sounds reasonable. And then a question still in this area, is there a risk of getting contaminated when taking the mask off and putting it back on? Well, yeah. I mean, the mask is a barrier. It's not a magical, let's kill virus, a substrate. It's simply layers of cloth or fabric or paper, whichever thing you're using, which are going to be acquiring and becoming saturated with, theoretically, infected droplets. So the inside of the mask, if you yourself are sick, of course is going to be contaminated. It's right there. However, if one is wearing the mask for its 40 to 60% protective features with the surgical loop masks, then the external part of the mask, which is sort of filtering air droplets coming to you from the patients, is at some point going to have some degree of contamination. So, yeah, there is a risk of getting contaminated. However, if, as is proper for donning and doffing PPE, one performs hand hygiene after doing that, then the risk is mitigated extensively. So, if at all possible, proper procedure for taking off the mask is to do so handling the edges of the mask. So not the fabric of the mask right in front of the mouth and nose, but at the edges, or even, if possible, take it off handling the loops only, and then discarding the mask or sending it out to someplace to air dry, and then immediately going to perform the hand hygiene steps, so the alcohol-based hand cleaner or soap and water. That altogether is going to be a major way to mitigate the risk. Last two questions, which I think are related, and these are fascinating too. I'm concerned that though children tend to have milder disease, there may be long-term sequelae that we don't understand right now. And I think, quite related, what if there's a COVID-19 version of rheumatic fever? So I tie these two together because I think what we're asking is, knowing that mild disease can occur, yet it might still trigger an immune reaction which down the road may precipitate autoimmune disease. And the multisystem inflammatory syndrome in children, the MISCI kids, are a perfect example of that. That is absolutely an autoimmune-driven vasculitic attack with multi-organ involvement. What if there's something like rheumatic fever where that can occur, but in much more delayed fashion? Great questions. We, of course, don't have the long-term data to answer those right now, but certainly that is something to be monitored, and I would hope that we'll continue to have long-term case series to demonstrate that. The morsel of hope, if you will, is that data from China, which has been thankfully robust in its reporting, to date has not demonstrated anything like that. So, yeah, we don't know what we don't know. Absolutely, I agree with that. All we can do is stay tuned and look for ongoing case series and data coming from parts of the world, including China, which first experienced the COVID-19 outbreak. And then on our own, also be quite vigilant and aware of that possibility. So, fabulous questions, a whole bunch in there, obviously ongoing discussions. I will close with this, that yes, Arizona seems to be over its most recent horribleness with decreasing trends in our community attack rates. Certainly we're no longer number one in the world, so that's a good thing. We are absolutely not done yet, though. And the question of return to school, the question of how to safely counsel our pediatric patients and their families, those remain to be addressed. This is a dynamic labile situation. And even the great Dr. Tony Fauci is very quick to point out that we continue to learn new things every day. So everything that I told you today, for all I know, in 2 weeks will be totally wrong. So please don't kill me if that's the case. I'm just simply trying to share with you what we know to date. So let's stay current. Absolutely. Let's keep our eyes open. Let's do the best that we can, case by case, for our individual patients and their families. And let's keep talking. So, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to COVID, that's COVID, at azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. Thanks for listening, everyone. Stay safe, stay sane, stay passionate.